Se supone que empezamos a las 10, pero no veo attendees. Entonces estoy dando un tiempo para que las personas se conecten.
Hay que iniciar la sesión, está el webinar arriba. Ligia, no sé quién está de host.
Yo lo puedo empezar, pero lo que me está saliendo es que hay 0 attendees, pero no sé si me sale porque no he activado el webinar.
Tienes que activar el webinar para empezar a ver empezar a ver a todos los participantes. Mientras estás en la sesión de práctica, no puedes ver a los participantes.
Perfecto, voy a activarla. Voy a activar ahora. Muy buenos días a todas y a todos y bienvenidos a esta segunda sesión del webinar sobre comunicación de riesgos.
Good morning, everyone, and thank you for joining us, the second session of our seminar, Contact Tracing, Communication of Risks and Participation in the Community for Contact Tracing within the context of COVID-19 in the region of the Americas. My name is Tanya Escamilla from Pajo. Today, we are presenting the second part of what we presented yesterday, in which we're going to look at the risk communication standard, community participation, and contact tracing. Then we will hear a presentation from Bolivia, who is and has been implementing this contact tracing methodology for a couple of months. In an agreement between the Catholic Church and Pajo, and they're going to talk about a project that they've been carrying out. Thank you. Now I'm going to share my screen.
Confirmo con todas y todos que están viendo.
I would like to confirm with everyone that you can see my screen, which I'm sharing with you now. Thank you. If you'd like to ask questions, do so through the chat function or Q&A. I would also like to remind all of the participants that we do have interpretation available. And all you have to do is go to the interpretation button on the bottom of your screen and click on that globe icon and choose your language. We're going to look at all the remaining parts of this handbook that we didn't see yesterday on contact tracing. We sent the link to you yesterday for this guide for you to download the document. We also sent a reminder again, that in relation to a link that we also sent you, which will enable you to see all of the different presentations that we've been presenting and will present in today's session and yesterday. Now, chapter 4. You may recall yesterday we went through 3, and so this is a review of the steps to carry out a communication campaign. Once you've had the opportunity to take a detailed look at the document, and you'll see that the steps that we included in Chapter 3 for a communication campaign have not only been designed from the standpoint of mass communication, but we also include other aspects in Chapter 3 for carrying out more local and community types of communication campaigns. This is a participatory process whereby we seek to include members of the community in the campaign. The communities are the recipients of information on one hand, but we also elicit feedback from the citizens and community to help us improve our communication campaign. We covered that in Chapter 3. Now 4, we delve more into the engagement of the community for contact tracing. That is, members of the community are part of the contact tracing teams. Now, this is a concept that the World Health Organization and PAHO recommend to be more successful in your contact tracing efforts. Why is it so important for community members to take part in contact tracing? We're talking about training members of the community for them to take part in these efforts. Now, here we have a number of matters where we underscore the importance of this practice, the reasons why this is important to spread information or to disseminate information and knowledge in to vast segments or to the masses, so to speak, to make people more receptive to receiving the information, to build routes of information that would make contact tracing easier, to create a sense of shared responsibility on health in the state or the environment, strengthening social tissue or fabric revolving around community care. Those who work in health communication to promote health know that when members of the community are involved, you can improve the collective well-being. And so we recommend that this be done to make the whole communication process to be collective. It's not just a campaign in which I receive information, but it's a matter of helping people feel a part of the process. In countries where the strategy has been implemented by PAHO, the communication of risk is more effective insofar or to the extent that the community members themselves are included in how this is done. It also helps to better bring together members of the community and the different players in the healthcare sector. Biosafety measures and follow-up measures are enhanced when the community is on board, And the community can also help identify possible problems. It was August of this year that the most recent guide was published by PAHO. It's a detailed methodology. If you don't know it, you should take a look at it. I will put the link in the chat from that August 2021 document. This is a methodology that applies in a social context. This methodology has to be tailored to each community, and that adaptation or localization, tailoring a process is greatly assisted by the local community. Now, the 11 key principles in contact tracing processes, the same 11 principles that we learned about yesterday. Monica Posada from the Red Cross told us about these 11 key principles that have been designed to stress the importance of engaging the community, getting them on board in the contact tracing process. Number one, to get to know the particular circumstances of each community, socioeconomic nature of it. The guide, the handbook, has a series of categories that you need to bear in mind before you even go to the community. The second principle is to build trust. We've talked about that. There are different techniques that can be used for that purpose. To gain the acceptance of the community. Now, in the diagnostics, adaptation process, the community needs to be a part of that. They need to understand what the process of contact tracing is. These aren't easily readily understood or easily conveyed. So that's why they should be included in the process. And to collaborate with community in finding solutions Recommendation 5. As I said before, this is something the World Health Organization and PAHO creating a community labor force. Number 5, the WHO and PAHO think that this is a very important one to get people involved in the reporting of their particular cases and of the community. 6, there needs to be a two-way communication process that's inclusive and candid, frank, open. Listen, analyze, and answer comments. Not just ask people what they think, but to act on that feedback. We've been asked why, during the pandemic, we can answer questionnaires. If you can't have contact, this can be done through questionnaires. No matter how you do it, if you're going to do it in person, you have to follow the health protocols. Telephones can be used and talk to community leaders about this adaptation process, localization of the methodology of contact tracing, make use of technology for the purpose of analysis and feedback by the community. 7 was to listen, analyze, and answer comments made by the community. That's what this two-way street is all about. 8, again, is making use of technology for contact tracing. Some of these devices have GPS, geolocalization, that enables you to know where people are. A person can, in numerous ways, using his or her smartphone, provide information about location, status. 9, to not
En esta presentación vamos a ver
actions. We're going to talk about that a little bit later in this presentation.
varias palabras o terminología que apunta a no criminalizar versus
We'll be talking about what that means to not criminalize this. The whole reason for contact tracing is to help improve the health of the community. People need to be told that it's not to point fingers at those who might have COVID. We're not criminalizing anyone. That's what that means. Encourage and confront cases of discrimination, rumors, stigmatization. Disinformation is rampant throughout the pandemic, and we need to counter that face on. Coordinate with everyone who has a hand in the response at all levels. Community organizations, so folks on the ground, community leaders, again, I say, and anyone on site where we're going to be working. These are the key aspects that I was talking about before that help us build the communities or trust in the community. You need to have a good understanding of this before you go to the community. These are indicators. It's good to know what people's beliefs are, religious beliefs, what their interests are, the socioeconomic situation, social context, ethnic aspects, risks entailed by going into certain communities. Unfortunately, that's something we have to deal with in our community, in our continent rather. There are indigenous communities and there are other groups that have their unique cultural heritage that we have to be sensitive to. Something else that's important is to establish a language to speak directly with people on contact tracing and doing contact tracing. You don't want to use terms that create or have a negative connotation. You want to use terminology that might have positive connotations in a given community. You don't want to talk about isolation. I'm a rather confinement might be viewed negatively. Isolation, less so. Locking someone up sounds awful, but home care doesn't sound so bad. Restrictions sounds negative. Measures, not so much. Avoid contact is worse than virtual contact, not in-person contact, but rather virtual contact is better than avoiding contact. Infection hotspot or sounds awful, but a chain of spread doesn't sound so bad. So these are just examples of how you can be mindful of the language you use to not have it sound so negative. Chapter 5, you're going to see some tools for the implementation of a communication strategy for contact tracing. Advice on using social networks to instill greater credibility. Also, different websites, links are made available where people can learn about contact tracing. We'll be providing you with all the material used for this webinar, including recordings. We have some model posters that can be used. There are some scripts that can be used for videos, such as for influencers to use, audio and video material. This is my story, in quotes there on the third item on the right, as a way to approach telling one story. You tell people your story, you engage people, get them to take part in the contact tracing, you explain why it's so important. That is focused on young people. These are scripts we make available to you. Of course, you could and should adapt them to the unique context where you work. Myths and realities on contact tracing. Short messages for educational purposes to inform people about contact tracing. Lastly, we have a radio novela, a story broadcast over the radio. This is like the script to it, following the path. It's titled, and that just is a little skit that teaches people about contact tracing. That was my presentation. You can ask your questions in the chat box or Q&A. I don't know if there are any questions.
Bueno, pues un poco para animarles a participar, quiero realizar ahora un pequeño ejercicio en
Let's do a little
línea.
exercise to break the ice and get you all engaged, excited about taking part. This is a tool we use. If you look up on my screen, well, this is a Menti survey. Two questions, very simple ones. So on the link, Menti.com, you use that code 833322952. Which words would you use in a contact tracing public message? So again, you go to that website, Menti.com, you put this code in, and you will get this screen. And there are our answers from the people who have answered the question. Francesco, you have a question or a comment?
Sí, disculpe, estaba buscando entrar en menti.com para ver eso. Me parece
I was just trying to get onto Menti.
la presentación me ha parecido bien reflexiva.
Your presentation reflects very well our experience. We've had to fight against stigma in the monitoring and contact tracing that we've done. Thank you. So here we can see the results of our survey question. So the question was, which words would you use in a contact tracing public message? Of course, it's in English and very small print under the bars. Home care, many chose that. Second, confinement, no one chose that. That's precisely what we recommended not be used. Measures, 13%. Figures are still changing as people answer. Establish virtual contact or chain of transmission and source of infection.
Muy buenos días, Albert. Quería ver qué había en el
Good
Google.
morning, Albert. I wanted to see what was there. Okay, so we have 21 this far, 22 now. I have another question for you. So those of you who have not participated, please do so. It's really very simple to enter menti.com. You introduce the code number, you input your responses, and now I put enter. Well, very few selected the infectious foci. So congratulations to all of you who participated. I'm now going to, well, you're still voting, and do so anyway, because at the end, you have the whole hour, or at least what's remaining of the webinar, and then we'll show the results at the end. I will now go to the next question. This is the next question, which is really not a question, it's more of a statement. These are recommendations to design communications for contact tracing. And you'll find that there are several options in that question. We're using comparisons, percentages, long communications with a lot of pages, use messages including a call to action. Fourth, using technical detailed reports with diverse instructions. 15, I'll do the enter now. And of course, 58% to the call to action. All communicators know that the message must also have a clear call to action as long as it's possible. I'll give you 30 seconds more, then I'll correct, and then I'll get the complete answers. Okay, we've reached 29. And in the correct, we have used comparisons and percentages. This is something that we've found in other types of campaigns, not just in PAHO, but we know that it's used frequently. The comparisons and percentages are things that clarifies the information for the person hearing it, particularly when you use the comparisons and percentages in short sentences. This is a strategy that's often been used in contact tracing communication campaigns recently. In fact, we've seen it used also in the COVID vaccine vaccination campaigns. And of course, the messages that call to action. In the case of technical reports with detailed and different instructions, it's not that it's incorrect, because we know that technical reports have an important scientific value and a technical value. But to communicate a message to the general public that does not know about contact tracing, it might not be the best option, especially if you include different types of instructions, because that could confuse the person. What we've seen in contact tracing and other experiences is that to give a series of simple and short steps makes understanding much easier. And on the other hand, long and lengthy communications with lots of pages we know are useless, because people tend to read short statements. This is practice that we see is growing. People are not in favor of reading long paragraphs or pages, I should say. Even on Facebook or videos, if they're more than a paragraph long or a minute long in the video, it's not that we're in favor or against them personally. I think it's terrible that people don't want to read, but to communicate with the general public, we must try to make the communications shorter and with brief but clear content. Thank you all for participating in this very brief exercise. And now we'll have a very short 5-minute break to allow you to get up, stretch your legs, have a glass of water if you wish, and then we'll come back with the presentation of our colleagues from Bolivia, whom I will introduce at 10:40. So be back in 4 minutes.
Estamos de regreso del
Very well,
break.
we're back from our short break. And thank you to those of you who are joining us now. I want to remind you all that there is simultaneous interpretation available at the bottom of the screen under the interpretation button that you see on the right side bottom of your Zoom screen. As I mentioned, the Q&A or chat is available for you to ask us questions, or you can also raise your hand when we're doing the presentations. I'd like to introduce our next speakers, the group from Bolivia, who's going to talk to us about their experience in a communication strategy for contact tracing, which involved different indigenous communities from the Bolivian Chaco from the very beginning. And today, Francesco Cosmi, Director of the Health Treaty of the Church's Social Work, Sandia Padilla, from the mobile team, Isabel Retori, social communicator from the Health Treaty. And I want to thank you all for being with us here today. Francesco, I'd ask you before you begin, I'm going to start projecting your slides, but can you tell us a little bit more about the work of the social treaty or convention? Convenio social. Thank you, Tania, for this presentation, and thank you all for giving us this opportunity to share our experiences here in El Chaco in Bolivia. As Tania was saying, the health treaty or agreement is a social pact, which we've had since the 70s, thanks to the work of Father Narciso, a Franciscan priest who began to work in health and trying to find public health strategies, also hand in hand with the indigenous communities of this territory. The El Chaco, the Bolivian El Chaco, is a pretty large territory. We know that it is shared by Paraguay and Argentina and Brazil. And then the Bolivian side, that's about 128,000 square kilometers. And a pretty small population, it's only maybe 300,000 inhabitants who are concentrated mainly in the cities. Of these, a third of them are indigenous populations, especially the Guarani populations. But there's some in Tarija, in Bonaire, and Tapieca. As I was saying, it's a very large territory with very little infrastructure. The whole territory has only one asphalted road, which goes from Santa Cruz to Argentina for international trade. And then the rest are all land roads towards the communities, pretty remote, pretty neglected. To give you a little bit of context of the activities we've done, we'd first have to begin by telling you how the pandemic arrived in the Guarani communities. Well, first of all, I wanted to give you an example, really, of some of the indigenous organizations' examples, where they said that in this pandemic, we're not all on the same boat. We're all in the same water. We're on yachts, we're in boats, we're in lifesavers, and some are just swimming away. And so just to tell you that in El Chaco, it was already difficult from the beginning. We have a chronic difficulty of very little access to water. Most of the communities and atajados, which are artificial lagoons or lakes, are the only places where they can save the rainwater and share it with the animals. And that causes several health problems with some of the postas, which they have, the mobile postas, are not equipped to deal with that emergency situation. Especially at the beginning of 2020, the situation was terrible. They didn't have gloves or masks or alcohol, so the situation was pretty complex. And we're dealing with a population that has different basic chronic diseases, and the one best known and maybe the most neglected is the Chagas disease, which is an endemic disease in this territory. And it's not often seen. It's one of the most hidden diseases. Now, aside from that, we also have hypertension, diabetes, epilepsy, malnutrition, particularly child malnutrition. And during the pandemic, that has been most neglected because there's been no care, no drugs, nothing. From the beginning of the pandemic in 2020, we began to establish some type of communication mainly focused on the urban areas with very few interculturality, not only due to the language, but also due to the context of the biosafety measures that were being implemented. So the organizations in these communities joined and tried to find solutions with what they had. The first step was to close access to these communities, as you see on that picture, to avoid spread. They recovered the traditional medicine, first because, as we say, these communities trust this medicine more, and also because it was the only one they had available at the time. And there's a very interesting experience in the chipi plant, which was used often to counteract the symptoms. And then the serious problem was Someone has a microphone on. The equipment of the health center and the training of these. So the communities, thanks to the health agreement and PAHO in 2020, set up a project to strengthen the equipment in the health centers and training the health staff, and strengthened also the community protocol to counteract the disease. So from 2020, we can say that we were at least able to reduce access to the communities. Now, starting this year, 2021, next slide, please. In Bolivia, we received a third wave of the disease, which has been the worst and has coincided with the winter season. We had a very cold winter and has led to a larger number of cases, many more cases in the community. That's why we've had to work more and had to strengthen the contact tracing and monitoring as a strategy to reduce the spread of the disease. And we've worked with two main components. The first was training and strengthening the tracing. There was a national protocol, but it wasn't being implemented. It wasn't being given the necessary importance to reduce the contagion. And the other part of the communication, as Tanya was explaining before, it was to have to fight against the stigma that's been created around this disease and the denial of the disease. So we have to work with risk communication, with intercultural material prepared to mitigate the impact of this disease. Next, please. Now, those two spheres, and I'll let my colleagues speak in a minute, and so far as the strengthening of the tracing and monitoring, one of our key actors were the health promoters. The health promoter and the people who have acted as a bridge between the hospital, health, and the community. It's someone from the community, and he knows the language. They speak Guarani. Their second language is actually Spanish. So the health staff and the health promoter was chosen by the community itself to offer them, to help them. And he does volunteer work, always in coordination with the health personnel. This health promoter's figure has been key to our access and acceptance from the community. On the other hand, insofar as communication is concerned, next please, we've seen that the key strategy has been the use of radio as the main tool to reach the communities. The WhatsApp and the megaphones are always accessible, but the radio has been fundamental for us to actually access a territory which is much larger than we expected. We've worked in 62 Guarani communities, but with the radio, we've been able to reach a lot more. And it's a participative radio, actually, where the health promoters and the authorities managed the message and spoke about the topic. So at a community level, we heard well-known voices and also messages which were related to the reality, and often in Guarani. That has been, I think those have been the two main components that have helped us. And now I'm going to give the floor to Licenciada Sandra Padilla, who's a Guarani anthropologist, so that she can explain some of the specific activities that took place in the community. Thank you very much. Good morning or good afternoon to some of you. Can you hear me? Well, continuing now with the presentation, I'd like to share with you some of the activities that took place in the Chaco, the Bolivian Chaco. I'd like to introduce myself, Sandra Padilla. and talk to you about some of the activities developed in El Chaco, which were mainly based on the needs of the communities. And 156 participants, health promoters and health staff, participated on different subject matters, which had the community in mind, hoping to replicate the knowledge of these health promoters and health staff to bring new knowledge about this problem of COVID, which it was initially unknown in the communities. However, as a result of the training, we've managed to understand and have the communities understand using different types of teaching methodologies. As you see here, we have some material prepared by the health staff after training themselves on some of these subjects. And one of their tasks was to convey the information to the communities, adapting the material to help the communities understand the question of the vaccine in this case, showing the positive cases that we see there with the little red dolls and the negative cases with the green dolls. And this material helped the communities understand the danger of this pandemic. However, the training of the promoters and the staff was important prior to these activities in order to actually be able to help these communities. Here, I show you the trained health staff on the nasal antigen tests. This training meant that we had 72 trained staff, which helped them trust themselves and trust in being able to do the tracing and the testing for COVID-19 in the different communities at the people's homes. So this was actually not known in these communities. The World Health problem was something that these communities had never heard of. So thanks to this training, the people were able to go to the homes of all these people, 100% of the homes, in order to find new cases, which at the time the community would not have known and therefore would not have probably reported the cases, because up until that moment, it was taboo, as you can probably imagine, culturally speaking, and it was an unknown health problem. But through the different methodologies, like videos and pamphlets in both languages, in Guarani and Spanish, as Francisco was saying, they were able to understand the problem. On this slide, we're showing you the guideline which was prepared by the institution with the help of PAHO on the contact tracing and monitoring for COVID-19. We realized that the simple word of tracing and monitoring in the community was already a fear for them because they knew nothing about it. So one of the activities of the team was to make them understand what tracing and monitoring meant. And once the communities were able to understand what this was all about, they began to report and guide and orient based on what's in the guide. So another thing that was important was to share with the health staff and the health promoter, because they're the ones who, after receiving their own training, are able to then convey that information to the communities. And coordination with them was very important, so that one could do joint activities in these communities so that we could actually bring them the information based on the teaching materials that we had available, which were very useful in our communities because they focus on key elements and on important aspects of what COVID is, how we can take care of ourselves, how we can organize ourselves in the communities. And here we see how we've worked with the guide on COVID prevention. First, we took advantage of the care spaces, the healthcare centers for the community, but also while they were being cared for, we took advantage of that time to guide these communities who were waiting to be cared for.
That's why it was so important for us to offer this guidance to the community, that is our health, the health information as well as contact tracing information, because since we already had the community there with us, we were able to convey this message and make sure they understood it using this didactic material, which we put together, tailoring it to the culture, to the language, to the unique characteristics of this community. Then we distributed it to the community. What you see here is that there were 63 communities, 48 health centers that received this biosafety, basic biosafety and equipment information. People were fearful before. They didn't trust that they could go to the health center. But after receiving this educational material, they were less wary, and we were able to go to people's homes and carry out whatever intervention was necessary. And that makes it easier for the healthcare workers to carry out their jobs in a more normal way. The healthcare personnel of the location are key parties that can help a lot for prevention. Of course, we offer training on contact tracing. Again, that made it easier for us to be able to work closer with the communities, to capture more cases, follow up on the community and families. What we said before, is how important it is for there to be coordination between the healthcare professionals and the community to provide the community with good information. We're talking about community leaders, local people who know their communities very well. These are all key people, players who can really help us offer care and preventive guidance. That's why we work very close with all of these people. Oftentimes, we have to work with the different areas. And all of this is to ensure that people don't come into contact with suspect cases. The community understood very well. We've lost the audio. It's freezing, says the interpreter, breaking up. To prevent more cases, more spread of COVID-19. Welcome, everyone. I'm the person in charge of outreach and communication for our project. There are two components. We have training, as well as concrete and specific activities that we carry out. I'm talking about contact tracing and then communication. And we'll be talking about mostly the second component. It's also very important to stress different actions. The speaker is freezing, the image is freezing, and the audio is intermittent, says the interpreter. So I will do the best I can. This all happens within the context of the communities, in this particular case, indigenous communities. One of the activities that we offer is training. Isabel, I don't know if it's only me, but there seems to be an audio problem. Could you please confirm that for us? Maybe I'm too far from the mic. Try again. Hello, can you hear me? Well, let's see. Yes, well, let's see how this goes.
Como les decía, en el componente que ha sido el componente en el cual.
Again, says interpreter, the sound is 2/3 silent, 1/3 disparate words. We work with the different indigenous communities, some of which speak Guarani. The healthcare community, healthcare workers.
Hola.
Disculpa, Isabel, tal vez de pronto si apagas tu video.
Maybe if you turn off your video, then the sound will come through. The sound connection might be better if you turn off your video. Otherwise, it comes through intermittent. Yes, we have had some internet problems. That's why this is happening. Well, so let's try again without the video. I apologize. It does seem like it has improved a bit. The audio has improved a bit.
Me comunica, por favor, si hay alguna otra interferencia.
Please let me know if there are any other problems, interference.
No, se está cortando de nuevo.
Well, the fact is it's still breaking up.
A ver, Isabel.
Can you hear us, Isabel?
Hola, ¿me escucha?
How about now? It says Isabel. Can you hear me? Yes, we are hearing you now. Please proceed.
Hola, ¿me copian? Por favor, ¿me puede decir si me
Just
escucha?
let me know if you can hear me, says Isabel.
Sí, te estamos escuchando.
Yes, we do hear you.
Hola, ¿me escucha?
Can you hear me?
Hola, ¿me escucha?
Hola, por favor,
Isabel.
¿me pueden, ¿se escucha ahora?
Can you
Sí,
hear
te
me
estamos
now?
escuchando.
Yes, we are hearing you. Let's resume and see if you have more bandwidth left to than you did with the video.
Entonces les decía de que se hizo
So what I was saying
una primera acción con los promotores de salud
is first, we had a first meeting
para desarrollar
gathering with the community health workers to train them, to provide them with the information so they know how to use radio communications and other communication tools, helping them be more, reach their communities more effectively
cotidianamente, ¿no? En el trabajo cotidiano que realizan.
daily in the daily work they carry out as
Vale decir
health
que los promotores de
promoters.
salud para nosotros han sido actores
Community
estratégicos
health
porque
workers
son
have been
personas
very important to
que cada
us.
comunidad vive
These are
de
people
manera
from the
única,
community.
conocen la
They speak the
cultura,
language, they know the culture, they know the context.
además de ello gozan de mucha credibilidad, mucha confianza de la comunidad, por
And the
tanto,
community
son
trusts them
importantes
because they're well-known
para llegar
elements.
con el mensaje adecuado. Entonces, ellos han aprendido en esta primera fase a
In this
desarrollar
first
algunos
stage,
formatos radiofónicos que nos han permitido más adelante
they
grabaciones de
learned
materiales que hemos
how to
producido.
use the radio so they can broadcast the material that they have.
La siguiente, por favor.
Next, please.
Lámina. Hola.
Next, please.
Isabel, ya estoy cambiando las láminas. No sé si alcanzas a
We are
ver.
changing the screen. I don't know if you're seeing it on your end as having been
La
changed.
anterior. Sí,
The
la
prior one, please.
Gracias.
Thank you.
Entonces, se han producido varios materiales, principalmente
Different
radiofónicos, ¿no?
Material has been produced mostly for radio broadcast,
por la cobertura rural en el área indígena.
given the need to use radio to reach the indigenous communities who live in the countryside. The only messages that get through are by radio.
Y por supuesto que los materiales que se han producido han sido todos contando, tomando muy en cuenta
And
el lenguaje
we
adecuado,
use the
adaptado al contexto de las
language
comunidades,
adapted
sobre
to
todo
the
en
context
la
of the
prevención de las probabilidades de
community,
contagio del coronavirus y enfocado a la participación comunitaria en las acciones
and we engage the community to get the community to take part in the contact
radiales, microprogramas radiales, se han hecho
tracing,
también videos sobre las experiencias desarrolladas en
videos
algunos municipios,
on the different experiences that we have had in the
difundido principalmente los
cities.
materiales en una red que es la red de comunicación guaraní que
There's a radio
presente en toda la
communication
Chaco
network in
y
the
la
Guarani
comunidad
language.
pero también se ha difundido en una red nacional que
There's
es
also a
la
national
Red Herbol, y que tiene más de
network,
100 radioemisoras en todo el país,
100 in
la
fact,
señal de
stations
por supuesto,
that
en
broadcast that
además de ello, pero hemos enfocado
signal
también
from
en la
the
siguiente
network.
página, por favor,
Next slide, please.
acciones de comunicación en un programa de radio que se ha denominado el
Now there's a radio
Yazaré Como, que en
program,
significa despertando.
Yazaré Como, which means awakening, waking up.
Programa básicamente es un espacio
Basically,
de diálogo,
this
hemos
is
creado un espacio de diálogo
a
cultural
intercultural dialogue where different local actors take part with healthcare promoters, healthcare personnel, the different teachers and leaders of the indigenous communities, housewives, everyone who feels a part of this iconic venue on Saturdays in the Guarani language. And thus far, a number of programs have been produced, and we continue to carry this out. And hopefully we'll be able to do it next year as well. There's a community radio called Tekove Katu. There's a health school with the same name, Tekove Katu, which makes use of an intercultural model, which works under the aegis of in a health agreement that we have with the ministry. This radio was set up for nursing students to conduct practice drills so that this communication system can be used should it be necessary. Another event was organized for community communicators of the Chaco region. These are 50 local community broadcasters, communicators, as they're called, in the Chaco of Bolivia. This was a virtual conference in which they addressed guidelines for communicating risk, the importance of vaccination. They talked about the myths that are out there. This is the Chaco region in Bolivia. Are we still having sound trouble?
Sí, te escuchas, ahorita te escuchas como un poco entrecortado. A ver, intentemos de nuevo. Sí puedes.
You are breaking up a little bit.
Intento continuar. En la parte final de esta nuestra presentación, bueno,
At the end of our presentation, we will talk a little bit about the lessons we've learned about these activities, one of which was to strengthen, through this outwork we've done, advocacy work we've done, we've strengthened contact tracing, working in the indigenous communities in the Bolivian Chaco region, and the healthcare workers and the community health promoters have worked well together. People who were against vaccinating themselves, that vaccination aversion has been reduced. We've persuaded through this effort to get more and more people to be willing to vaccinate. That's been a lesson learned. It's not just a media onslaught, a media message. You have to get out in the community and actually work with people to win them over. It's very important for there to be this space of dialogue across cultures, using the radio, holding different events with the community leaders, health promoters. That's what has made it possible for us to effectively reach the population and convey the right message to them. something we've seen evidence of, is how important it is for there to be ongoing training, especially in the rural communities where people have a harder time reaching wherever they would otherwise be able to get training. Virtual courses were made available for offering this training to healthcare workers and community health workers. Now, going forward, we will continue to promote, motivating, encouraging community health promoters who do this on an entirely voluntary basis. They do this just out of a sense of service to their community. And we want to support them in this process. With these different programs we have, like the Yasarekomo, which is a bilingual program, or rather radio, as we talked about before. We use the handbook for monitoring and contact tracing, the community handbook that was put together for COVID-19 prevention, other worthwhile and useful tools that healthcare personnel and promoters have found quite useful. Through the Chaco Health Service and the agreement that was signed on to there. Thank you, Francesco and Isabel. We thank you very much. Now, I would like to open up the session for questions. I thank Sandra Padilla for her participation. Now, if questions do come in, I would just ask you to keep your video off to make sure that you have as much bandwidth as possible for your voice to get through. You can go to the Q&A on the Zoom platform to ask your questions if you don't want to use the chat. Now, from Costa Rica, from Pamela Monestel, she asks, how did you go about vaccinating people? How much resistance was there? How did you address that resistance on the part of people? Did you make use of traditional doctors in that vaccination process? There was one community where there was a lot of aversion or resistance to being vaccinated, a Christian community, which culturally just did not accept vaccines. We enlisted a pastor from another community who was able to explain the importance of vaccination and linking that to faith. He said that God was who made man wise enough to create such a vaccine. So that interview was done by a healthcare promoter, also from another community. The community, when hearing a pastor talk with a healthcare promoter, that helped overcome the resistance to vaccination that this community had. They came to understand how important vaccination is to prevent COVID. So in a single day, we raised coverage from 4% to 52%. So that was a strategy that worked and can be applied, again, within the context of each community. So you have to see how best to reach a given community, making use of key people who could facilitate that message. That experience has been very helpful, enabling us to replicate it in other communities. Taking into account people's cultures and beliefs. And so it's good for that person that you enlist to help you be from the community. Our colleague from Bolivia has connected Sandra Mayo from Colombia, the PAHO office in Colombia. Thank you very much, Sandra Mayo, for taking part. I give you the floor. A warm welcome to all of the participants. I would like to thank the promoters of this project in Bolivia, the healthcare promoters. I apologize for the connection that we have had. The Chaco region, you must understand, the fact is there are many difficulties there, some of which one of which is a lack of good connectivity in the rural region in Bolivia, and where this project was carried out. Community work is very important for us to ensure that we are able to work with the most vulnerable populations. Now, in the Guarani world, time is circular, not linear. So you have to take the necessary time first for people to understand first the pandemic, how it arrived, and try to help them understand the complexity of these concepts. So you have to understand how complex contact tracing within the context of the pandemic has been. And I'm grateful to all of the people who have taken part in this effort, especially the community health promoters who have worked hard to develop the content for the radio and other outlets and means of communication. It's very important to have a true dialogue, to get community buy-in, engage the community. I thank you, Tanya, headquarters, for having helped us, PAHO and WHO, for making available to us the financing necessary to carry out this project. I thank you. Hopefully this is a recurring event here whereby we can hear from other countries what their experience has been. Feel free to share your experiences with us during this webinar. Now we have two questions, one from Costa Rica. Luis Antonio Fernandez, I thank you for your question. Luis asks the team in Bolivia, is there an indicator of the effectiveness of the communication process as regards changing the population's behavior and what the usual expectation is of how people will behave? That is, whether they're going to start washing their hands and so forth, other behavioral issues. So that is a big challenge that we have. How to go about changing people's practices and behaviors, and do you have any indicator to gauge whether behaviors have actually changed because of your efforts of communicating risk and so forth.
Bien, pregunta, sabemos bien que la parte de los indicadores es fundamental para valorar.
Now, we do know how important the role of the communicators is from the outset to have a good impact, but the information that we have in El Chaco isn't always so consistent. But in those communities where we're working, we've reached a 68% coverage of vaccination, especially in those communities where there's a general consensus and willingness to be vaccinated. That has been a remarkable success, as Sandra was saying, because there had been a huge barrier. Evangelical sects, for example, that prohibited access to vaccines, saying that if you got vaccinated, it can only mean you don't believe in God. And the fact that we reached 68% vaccination coverage in our community and that we have replicated that in others is a watershed event for us. Now, in outreach, it's interesting to identify those communities that just simply seem to be using common sense. Through radio and social media, we've identified these communities. Before, the problem was that people didn't really understand the nature of this disease, of this problem. Then we carried out this communication campaign, made visits to people's homes, and that helped people understand how best to prevent the disease with the guidance of healthcare personnel.
And one final thing, as to the personal attitude one must have, we have to say that here, the community contribution has been very important. We see that there's been a real change. We know that there are constant meetings in the community that used to take place within closed spaces, and now all meetings are done in open spaces, and all of them with the mask, something which never existed before. And another interesting aspect is that as to the family quarantine of cases that are detected or suspicious cases, it's important to mention community participation. The community is supporting the family quarantine. We know that often we don't have access to water or to food in the homes. So through the health promoter, there have been groups organized so that they can bring them different types of services, like bringing them water or bringing them corn, and help them so that they don't feel alone or discriminated. And that it is a problem that the whole community is living, is all aware of the risks. I also would like to add regarding the communication actions that took place at the very beginning of the whole program. We carried out a brief study to know how much they knew about the contacts and the contagion. We did surveys to see how much the community or the health promoters knew about tracing and what it was for and how it was done. And we used that same questionnaire at the end of the process, and we saw that the knowledge on this has increased considerably. And of course, the new habits that they have acquired, which help avoid the spread of COVID. Thank you very much, Isabel. I think that the vaccination percentage is a clear indication of a change of behavior. if there was a baseline that showed initial resistance to the vaccine, and now I feel that that percentage clearly shows the success of the process you carried out and the clear change in attitude and behavior in the community. We have another question from our colleague Gail Thomas from Pajo in Trinidad and Tobago, who asks about the radio program that was used at a community level. First, asking whether the narrative on the radio and the development of the messages were at all times controlled by the community and health promoters who were part of the group from the very beginning. And if that was so, how were you able to avoid the misinformation from going through? How did you avoid it getting into the program, or how was it dealt with in the program in the right manner? At the beginning, the health promoters were offered training so that they could handle the tools and the phone format. We felt that it was essential to begin the process. The process was designed by the team. We designed it with a variety of formats, informational, musical, drama. So we worked a lot with these formats so that we could reach them in the best possible way. And then slowly, the health promoters were added with news sent from their communities, as well as with interviews done to themselves, telling some life stories, motivating people and serving as an example for other places, getting the health promoters as well as the different community agents involved. The program has a specific format, structure that is well defined and has been maintained as is from the very beginning. Thank you, Isabel. Another comment here from our colleague, Lucy Serrato. I'd like to give her the microphone and allow her to make the comment. She talks about certain actions done in Honduras. Lucy, would you like to talk about your comment? Take the floor and talk to us about it. Lucy? I don't know if Lucy's still connected. I'll read what she sent us so that you all bear it in mind. It says that in Honduras, they worked very hard from the beginning of the pandemic with actions similar to those of the colleagues with contact tracers. We did find barriers, including some churches and cosmovisions, but we have obtained a lot of support from the community leaders. Related a bit to what Francesco was saying at the beginning of the presentation when he spoke of how they had to work initially with the balance between the indigenous people's cosmovision and the campaign messages and the different communication activities that were done. I would like to ask a question myself, because I'd be very interested in knowing how you were able to get the health promoters and authorities agreed to certain communication processes, which doesn't always happen. They don't always want to be involved in these radio programs. I'm just curious about that. I wonder if you could explain to us how that experience was. But first, I see that there's a colleague from Honduras who's raised her hand and is going to expand on Lucy's comment. Karina, you have the floor. Karina. Don't know what happened with Karina, but Francesca, Isabel, or Licenciada Sandra, could you tell us a little about how you managed to get the health promoters and the other health authorities involved in the communication activities, which I think is a great experience because sometimes there's a lot of resistance and fear of live participation. Tanya, can you hear me, Tanya? Yes. Can you hear me now? Can you hear me now, Tanya? Yes, we now have a microphone. I'm Karina, I've said from Honduras, and my colleague Lucy Cerrato had commented in the chat about all the different actions that we've been doing at a community level, which are very similar to what they've done in Bolivia, in El Chaco. It has been a very gratifying experience. We still have had a lot of barriers because in Honduras, we have 9 indigenous peoples. We've worked very closely with 2 of them, and we've approached the third one. The barrier for us at this time continues to be their low risk perception. And that's a problem socially and the general problem in Honduras. But the contact tracing was an excellent opportunity for us to be able to reach many of these communities. And I want to take advantage of this opportunity to congratulate you and all of you for all these initiatives that help us and motivate us to continue to do this community work and to try to approach these communities. I also want to mention that we are carrying out a project now which has allowed us to approach the communities with health promoters. And we have health promoters identified in the project who are working closely with the community. And I'd like to tell you a little about our experience, if you can give me a few minutes more, Tanya, of the translation that we did of the material to the 2 ethnics that we've been working with, which is the Mezquita and the Garifuna. We translated the communications tools that helped us reach them with effective messages in their own language. And that has been quite well accepted and has motivated us to continue to translate these educational materials. And this has had a very positive experience for us to be able to work closely with the leaders that live within the communities, because one of the interesting experiences, and this is the third one that we've had, is that we must work with the leaders in each community. We can't move one leader from one community to another because that's not allowed by many communities. And an example I'd like to mention, which taught us a lot recently, we went into the Honduras Mosquita, which is a remote area difficult to access except via air. And we reached a community where, surprisingly, you cannot do any work with the community leaders themselves. So we had to bring leaders from another community. And in that case, we had an effective message because there was low risk perception. They were not willing to vaccinate. The church was, I'm not going to say exactly what religious denomination it was, but there was a strong religious component preventing the community from vaccinating. So all of these ideas are similar to what you've shared with us in the webinar, and they've been very helpful for us. We want to thank you very much for sharing this knowledge with us. And we wanted to tell you a little bit of what we were doing here in Honduras. We continue to work with my colleague, Lucy Cerrato, and Ramirez, and all the communications team here. We've done a lot of work, very gratifying. We continue to work, we continue to advance, and contact tracing is an effective tool to avoid the spread. Thank you very much for this opportunity, Tanya, and to the whole team. Thank you, Karina, to you. And we'll stay in touch. Maybe at our next edition of this webinar, we can hear Honduras's experience so that you can tell us in greater detail. And now I'll go back to you, Francesco, Sandra, and Isabel, the Bolivian tool. If you can tell us a little bit more about the health promoters and authority promoters' participation in the radio programs. Yes, very interesting what they tell us from Honduras. It somewhat reflects the necessary journey required with these communities. As Sandra rightly said before, we have to begin by hearing, by listening. And the work that we've been doing here in El Chaco for years now is the community it's a multifunctional team which is made up of Guarani members, who go to the different communities, hearing their needs, listening to them, and sharing with them the problems and the needs. It's a participative activity. Often health is only left to the health professionals, and we don't manage to get the real actors involved, the ones who are really going to be able to change the health system. That's why we think it's a necessary journey that teaches us how to listen, to re-evaluate many of the things that we hear about, like traditional medicine, for example. Often we don't give it the importance it deserves. And we recognize that it's a key element in the day-to-day activity of these communities. And if we don't recover that, we're not going to be able to get into the communities. We have to find a way to give them space. Father Tarcisio always taught us that the example, that setting the example as the 169 agreement of the ILO is to give them all the necessary things so that they can offer their own health services and under their own control, which is a little of what we do. We create a space which gives them the opportunity to speak. Often in front of the health professional, they're a little bit ashamed, they're a little bit shy, they're not willing to talk. Maybe they don't speak the language correctly. Spanish might not be their first language. While with the team, they speak in their own language, in Guarani. They sit around the table and they encourage the participation, so that it's the community who actually owns the health system, identifying their own priorities and recognizing their own needs. So when we've given these people opportunity to participate in the radio campaign, actually the response has been very broad, because the health promoters have been more than willing to participate. We always work together with them through meetings and assemblies. We talk to them, we listen to them, and then we help them define their priorities, and we interview them and hear them. And I can assure you that when there's been flow of misinformation through the media and the social networks, or WhatsApp or Facebook or what have you, no one had managed to stop that. Different information came up, fake information came up all the time, and to hear the work of the promoter validated everything that was being said. So, as I said, as they seem to be doing in Honduras, which I think is possible, is to give the communities the floor and hearing them, because they are the ones that have to help change the change. We can only offer a little grain of salt there, but they are the true agents of change in public health. Thank you very much, Francesco. I saw that Gail Thomas had raised her hand. Did you want to speak?
Ask a question or make a comment? Bueno, no sé si Gail puede.
I'm not sure if Gail can turn on her microphone. I believe I have to activate them. Let me see if I can do that, she says.
Gail, I just activated the option for you to speak. So you want to go ahead? Bueno, no sé si Gail ya le activé la opción
I have
para.
already given Gail a chance to speak. You have a chance to turn your microphone on, Mrs. Thomas. We have another question in the Q&A asking about the network of community radio stations that you used for your campaign. Do you feel that that was a strength to prevent the penetration of misinformation about or fake information about COVID-19, having this large network of radio stations at a community level? Do you think that had an influence of acting against or in response to the fake information that was coming through the social networks about the COVID? Yes, without a doubt. That was a strength which we used. These were instruments, these radio stations we used to counteract the misinformation and fake information that was going around, which was often negatively influencing the population, especially on aspects related to the vaccine. So it has definitely been a strength, our using the stations, and it has helped us expand the action, the coverage, because though the project includes 3 intervention municipalities, however, with the radio, we've been able to reach up to 16 municipalities in the Bolivian Chaco, which we said at the beginning is a very large area. Geographically speaking, it's very large, and it has a variety of cultures within the area. So we definitely believe that the use of the radio was very important. Thank you, Isabel. I have one final question to end the webinar, because yesterday we heard the experience from Colombia, where the colleague from Colombia talked to us about the importance of WhatsApp because of the tremendous penetration of WhatsApp in that country. Not only the WhatsApp, but the possibilities of connecting and contacting in remote areas. What we saw from your experience in Bolivia today, which is different from Colombia and specifically in El Chaco, is that the community radios you considered were much more effective than the WhatsApp. I was wondering whether you did any test or any review, or how you got that information. How did you realize that in that region, the main channel was the community radio? Well, in answer, we analyze the situation and our reality. We know that not everyone has the cell phones, not everyone has coverage, and recently not anyone has the money for it. So we have tried to work with the promoters initially. Some of them do have cell phones, and the health staff sending them messages, but we realized that it was really very difficult to share the message with them, the message that was on the cell phone with other people. El Chaco, here we know that the teacher at home, I'm sorry, I'm losing him and I'm trying to figure out what he's trying to say, but his voice is coming in and out. He's talking about the teacher, I think, and we had a program where we were able to prove that the audience was very significant in the communities where we visited. Outside the project, everyone knows about the program, everyone hears it. The radio, I'm imagining he's talking about a radio station, but sometimes with the radio, we don't know how many people you're reaching. And we found that we had reached a lot more people than we thought, and respecting their idiosyncrasy, their language, their context. So in El Chaco, definitely it is the tool of choice to reach the homes of all families. Thank you very much, Francesco, and thank you to the team. And with this, we can appreciate the diversity we must take into account when designing a communication campaign in health. Not all territories use the same platforms. Yesterday, we saw the Colombian experience with a massive communication campaign where they used or are using, and in fact, tomorrow they'll be launching the campaign using the commercial radio and WhatsApp. Colombia also showed us yesterday the other face of the work that they do with the rural communities, where educational and training aspects are so important, and the face-to-face experience was very important for them. And now, hearing from Bolivia and their experience in El Chaco, we see that the cosmovision, the indigenous cosmovision plays an important role, the oral and traditional, and the radio, the community radio stations, which are so important in Latin America. And I would say that in all of America, but in all of Spanish-speaking America, the radio is historically known as having an important protagonism in health communication or development communication. I want to thank the team from Bolivia very much for their participation. We were able to continue our meeting despite the communications problems. Thank you all for your participation in this webinar. Thank you all for your questions. I put my email on the chat. We're here at the Pan American Health Organization to help any country who may wish to contact us to share their experiences. In the chat, I mentioned that it's not only contact tracing. There are other aspects that have to do with risk communication and response to the COVID-19 pandemic. And we hope that this will be one of many more webinars where we'll have a chance to hear of the experiences of others to enrich our work in the countries and at a regional level. Thank you very much again to all of you. I wish you a good rest of the week, and I hope you enjoy your free afternoon.
Yasuropai Twicha, como dicen en guaraní, muchísimas gracias. Tumpan divino, que Dios lo acompañe y lo cuide en ese trabajo